We have to go on. I try to. Oh, so we have time again. I tried to be fast in my presentation about neuromodulation and neurostimulation. You stop me because you know I like a lot neurostimulation and neuromodulation. I can start to speak a lot about it. So the history of neurostimulation in neurogenic bladder is long, and the attempts to stimulate directly the sphincter or directly the bladder start in the beginning of last century, and we arrived in 60 years to try directly in humans in the sphincter, in the bladder, and Muro has been the first that said we have to work on sacral roots, and in the 80 years, we arrived to the Brindley approach. Brindley approach has been really the revolution of a direct stimulation of anterior sacral roots with a posterior rhizotomy that was developed by Sauerwein, because in the beginning they used only the direct stimulation of sacral roots. But the Brindley era has been really the revolution. I remember that I was really excited in 1990 when I had the occasion to do the first implant of Brindley system and to see the restore not only of the bladder function, but also in some patients of bowel function and sexual function. What are the problems? The problem is that we have to perform a posterior rhizotomy, and today, if you are honest and you speak with a young person with a complete lesion of spinal cord and you propose the thing, they are waiting for the miracle, for stem cells, for something different. And so, and also the Brindley approach is invasive, and the revolution of the use of something less invasive like botulinum toxin has been really the death of this kind of approach. I don't want to lose time to about the Brindley, but really it's able to restore a good voiding, even if it's not a physiological voiding, because is what is defined as the post-voiding stimulus, because you have the contraction of the bladder and you have with the same parameter to obtain the fatigue of the sphincter, and you obtain this kind of voiding. The same, we had some results. We have 20 patients with the direct stimulation of S2 in erection and the stimulation in S3, S4 to obtain a better bowel function. What is the lesson that we had with the Brindley system? That we have been able to understand the effect parameter related on the stimulation of the sacral root, and the possibility to have different programs and to obtain results directly with the efferent stimulation. But we can use this system only in a complete lesion, is invasive. Posterior rhizotomy, as I said before, is not accepted by patients, and we have some cases in long-term stimulation with a Wallerian degeneration of the roots. But this has been the lesson to understand what is really the function of the sacral root. Today, I always say that we have a box of the electrical system of the bladder, and we are able to enter and to do a modulation, and we are able to understand from the anatomy what is the function of the sacral root. And we know what are the function of every root, but also we know that we can use the stimulation for all the function, and I go back with the concept of sacral area dysfunction. The other revolution has been from neurostimulation modulation. Modulation has been the revolution by the School of San Francisco, by Emil Tanago, and if you see in '88, Tanago published the first paper about electrical stimulation domination of neurogenic bladder. This is the era of neuromodulation. Neuromodulation has been really a revolution in the field of functional urology, but if we look at the indication approved for sacral neuromodulation is approved for so-called idiopathic situation. In the beginning, it was really strange to say, what happens when I put a lead and with the same parameters I obtain good results in different symptoms. in patients with urinary retention and in patients with incontinence. And this has been that idea that I cannot speak about so-called idiopathic. I have so-called non-neurogenic patients, but in which I have something of neurogenic, because if I enter in the electrical system and with my stimulation I arrive to a good results, it seems that I have an undisclosed neurogenic situation. And this really, also in general urology, has been the revolution. I always say that normal urologist is prostatocentric, and in his mind it's difficult to understand that neuromodulation is something that arrives in our brain to control the bladder. Arrive because with neuromodulation we understood that it's not only a stimulation that we have around the bladder, but we had the possibility with neuromodulation to understand that we have not only an afferent but also an afferent activity, and this afferent activity is able to restore completely, to remodulate the function of the central nervous system. And so we arrive to these two categories: direct stimulation in patients with complete lesion, and neuromodulation in so-called idiopathic, but also in patients with incomplete lesion. And I think that the last 20 years for us has been really interesting in the knowledge of the function of the bladder. We know today what are all the stations that we have for sensation, starting from our bladder, for decision to void, and what we know as an output to control very well the bladder, and also with the study with the functional MRI, with PET scan, we know today a better control. And so I think that if we speak about modulation, we speak about something that is not an indication for incontinence, for retention, but is something that is able to modulate the lower urinary tract symptoms, motor and sensory, and is able to restore a control. What we assisted that we had a change of the method. The method in the beginning, we had the first attempts, and they were invasive, and also it was difficult to arrive with the approach to put a lead in S3. And I say to you before that I look at our pelvis as a box in which we have different doors in which we can enter, and we can have a door where to start to modulate the central nervous system. We developed the idea of the percutaneous treatment, and this has been really a revolution. It's still used worldwide, the time lead that permits in a short time to reach sacral roots and to start with a continuous modulation. But if we look, these are the indications, these are results that we have today. These are general results that we read in all paper. And if we look at sacral neuromodulation in neurogenic LUTs, we have some literature. We have some literature in which generally we arrive on group of patients that are modulated. And if you look at the data, we have studies with big heterogeneous group. We have inside multiple sclerosis, spinal injury, and even in this trial on 72 patients, if you look at the population is a very mixed population. And paper refer treatment of retention, refer treatment of neurogenic Detrusor or overactivity. But in the end, when you read, the conclusion is that these patients improve 50% of their symptoms. What our patients ask to us, not to improve 50% of symptoms. If I have incontinence of 200 milliliters and I have as a result that my incontinence is 100 milliliters, I still remain incontinent. I always say that. And so our patients with spinal cord generally want to have a complete control of their situation. So potentially it could be a good treatment, but for example, in patients with progressive disease like multiple sclerosis. In the beginning, there were good results, but in long term, we hadn't. The second problem is that we have patients in which we need to perform MRI, and MRI still remain non-compatible with that. Our approach started in 2003 with another possibility that we still use in incomplete lesion, that is to use pudendal nerve stimulation. With the same method, we reach pudendal nerve, and we obtained in these patients better results than the use of S3 modulation. And actually, this is our approach before botulinum toxin in patients with incomplete lesion resistant or with side effect with antimuscarinics. There are some attempts with genital nerve stimulation, and I think that one of the most interesting approach is the early approach after spinal injury with sacral or pudendal neuromodulation, because we know that the effect that we have very early is an effect that can work on the mechanism of the activation of different sensory fibers that are the responsible of not only bladder overactivity but spasticity and pain in this group of patients. What is the future? The future is really to find an answer in non-responder patients to improve our clinical outcome and to open new field of modulation. We need a change in the method and a change, we think, in checking objective response. This is a typical situation that arrived to our observation where the lead is not in the right position, and this was an implanted, and you see this is the right lead and the other two leads were without efficacy. The second is the possibility to have a good monitoring when you put the lead and to have the better afferent and efferent response. And probably in the future the possibility to have a check of what happens as a response in the brain. The other question is sacral and pudendal. What is better? I said before that today we prefer pudendal in neurogenic patients. With pudendal we have an activation not only of the afferents starting from S3, but starting from S2, S3, S4. And this activation permits in this approach to have better results. It's completely different if you have an acute stimulation of pudendal nerve and an acute stimulation of S3. With an acute stimulation in pudendal nerve, you have the inhibition of the contraction of the bladder. So this is the method that we use. And one of the questions is why not to use more than one lead? We have few patients that has been implanted bilaterally on pudendal nerve, also in two patients with a complete lesion, and in a working model, a bilateral stimulation could be better. Other attempts are to use a bilateral with a bipolar stimulation from each side, or the possibility to have a stimulation with different kind of IPG. The IPG that today we use are really old. They are really old because we are not able to use all the parameters that we want, and there are some attempts to arrive with the lead in other side. I go on because we have no time, sorry. In last years, we assisted to different approach, laparoscopic approach. This is the lion technique. It's a pity that Brigitte go out because we can discuss. And also in Brazil, there is the experience of Nucelio Lemos with an approach. And this is interesting and this is a promising approach. What is the future? The future is that we know nothing really about the better parameters, or we have not the right device for the better parameters. This is a very interesting approach in animals by the group of Pittsburgh, and they have been able to suggest the best parameters to obtain with the pudendal stimulation and inhibition of overactivity, that is the same approach that we have with pudendal, but with the bilateral stimulation, the possibility to have a contraction of the bladder and the fatigue of the sphincter. And this is perhaps the model that we will have for next time. This is the patient that has been treated with an implant of Brindley stimulation, with a direct stimulation, and with the pudendal modulation and escape posterior rhizotomy. And this could be the future. The future is that we don't know really what we have to choose as current. There are new trends. In last 2 years, there are new devices, but this new device don't promise in this moment to be technologically at the level that we want. What we need? We need a multiple channel device, a low and high frequency possibility, more flexible leads, and the possibility to have a closed loop and a selective stimulation. And especially we need to have the possibility to use MRI. And this, when we will arrive to this system, we will be able to treat all our patients. We have no time to speak about what is about the C-fibers, and I conclude that perhaps one other field for the future is the precocious modulation. That is not a treatment of the overactivity and of the symptom, but perhaps when we start in the beginning is the cure of overactivity. And so I finish remembering Brindley and Professor Tanago, and thinking that if we really stay with the deviation from the norm, we are able to arrive to the progress. Thank you.